welcome to my channel. This is a new course that I'm starting called the MBBS FlashDash, which is mainly aimed at final year medical students who need a quick revision before their finals. In this video, I will be continuing part 2 of the Ophthalmology Series. Do check out the links below in the description if you want written notes from my website and also flashcards which I've uploaded on Pinterest. So let's get started. In this video, we will be covering Herpes Zoster Ophthalmicus, Retinal Detachment, Cytomegalovirus Retinitis, Subconjunctival Hemorrhage, Acute Dacrocystitis, Acute Angle Closure Glaucoma, also known as Narrow Angle Glaucoma, Open Angle Glaucoma, Orbital Cellulitis, Chalazion or Meibomian Cyst, and also points of the nerves of the eye. Herpes Zoster Ophthalmicus. So Herpes Zoster Ophthalmicus is caused by the reactivation of varicella zoster virus in the ophthalmic branch of the trigeminal nerve. The most common disease or pathology caused by the varicella zoster virus would be the chicken pox. So if a patient has previously had chicken pox, the virus is already in our system. But how herpes zoster ophthalmicus occurs by the reactivation of that particular virus. Now, the trigeminal nerve is the fifth cranial nerve, and the part that it affects would be the ophthalmic branch in particular. Alright, so this is the ophthalmic branch. Now, the trigeminal nerve, once it divides, you have the ophthalmic branch, the maxillary branch, and the mandibular branch. But as I mentioned, for this part, for herpes zoster ophthalmicus, it affects only the ophthalmic branch. So the patient would have conjunctivitis, keratitis, pain around the eye, painful vesicles, or rash around the eye. There's also Hutchinson sign. So it's cutaneous involvement of the tip of the nose. Basically, you'll see rash formation at the tip of the nose, but sometimes it can even affect from here, from the forehead up till the nose. So you have to take note, it only affects the ophthalmic part. It doesn't affect the other part. So it's not visible at the cheeks, it's not visible at the jaw, just the ophthalmic part. Now, treatment for that, since it's caused by virus, you would give oral acyclovir or oral corticosteroid. Retinal detachment. So for retinal detachment, there's sudden, painless loss of vision, and here are 4 F's to take note: flashes, floaters, field visual loss, and fall in visual acuity. Sometimes the patient may say it feels as if it's a curtain falling down, like the vision as it goes black. It's like, it's like curtain falling down. Like if you were to attend a concert or maybe a play, you know how they roll up the curtains and then they roll it down at the end of it. So it's like that. Or there's dark shadow over my vision. Some risk factors to take note would be myopia, extraction of cataract surgery, surgically previously, any history of trauma a few days prior to the presentation. If you were to do a direct ophthalmoscope, there would be gray, opalescent or opaque retina, as well as ballooning forward. The treatment would be scleral buckling, that's the most important part, or you can perform a vitrectomy or a pneumatic retinopexy. So a little bit about Amaurosis fugax. So Amaurosis fugax presents similarly. It's also painless, unilateral loss of vision, with the sensation that a black curtain has come down over the person's vision. So as I mentioned before about how the presentation of a curtain falling down is like. Now, if in the exam they say curtain falling down, dark shadow over my vision, you think of retinal detachment or Amaurosis fugax. But what differentiates retinal detachment and Amaurosis fugax is that Amaurosis fugax, the vision loss is usually temporary and it will resolve in maybe 5 to 30 minutes. So as you can see here, it's due to temporary retinal ischemia. There is transient occlusion of the central retinal artery. Amaurosis fugax is basically like transient ischemic attack, like how you differentiate between transient ischemic attack and stroke. Transient ischemic attack or sometimes people will say a mild stroke, where the patient may present with symptoms of stroke, but it resolves within 24 hours, whereas a full-on stroke, the symptoms does not resolve within 24 hours. So amaurosis fugax is like that. The vision loss is temporary, it's for a while, and then it comes back. But with retinal detachment, it does not come back. Cytomegalovirus Retinitis. So a clincher to take note over here would be an HIV patient with eye or retinal manifestations. So some clinical features to take note of here. The patient may be immunocompromised. The patient may be suffering from AIDS, or previously or just had organ transplant, or maybe even a patient undergoing chemotherapy. So there's progressive visual deterioration. There would be floaters present and loss of visual field on one side. So if you were to perform a fundoscopy, there would be retinal hemorrhage as well as yellow-white areas of exudates. So over here, yellow-white area. It is also known as a Pisa appearance on the fundoscopy. So the treatment would be intravitreal and IV ganciclovir. Subconjunctival hemorrhage. It's usually symptomless, and it's due to a small bleed from a minor conjunctival vessel. It can occur spontaneously or even post-trauma. So you can see over here, it's very easy to identify. You will see redness around the eye, outside, and just think of subconjunctival hemorrhage. A hemorrhage has occurred. So the treatment, if this occurred spontaneously with no history of trauma and the patient is not an anticoagulant, so you just reassure. Usually it goes away after a few days on its own. Acute Dacrocystitis. It is an infection of the lacrimal sac. So the lacrimal sac, also known as the tear duct, it is at the nasal side of the lower lid, as you can see here. So it's usually from here to here. Clinical feature would be epiphora, watering eye, swelling, pain, and erythema. As you can see here, there's swelling. Obviously, the patient would feel pain, and there's also redness. Okay, at the inner canthus of the eye. Inner canthus is this part here because the tear duct is from here to here. All right, so it's at the inner canthus of the eye, but it can extend to the neighboring areas. There would be mucoid discharge, and when you were to press it, it can be expressed from the tear duct, from the lacrimal sac. So treatment would be systemic antibiotics and proceed with IV if there is associated periorbital cellulitis. This would be orbital cellulitis. Okay, see how acute dacrocystitis looks like? This is orbital cellulitis. So orbital cellulitis, obviously around the eye, the orbit. So it's a result of an infection affecting the fat and muscle posterior to the orbital septum. Earlier, it's just infection of the lacrimal sac, but here, it's infection affecting the fat and muscles. So it's usually caused by spreading upper respiratory tract infection from the sinuses, and it carries a high mortality rate. So it's a medical emergency. It's common in children aged around 7 to 12 years old, and the most common bacterial causes would be Streptococcus, Staphylococcus aureus, and Haemophilus influenza B. So clinical features, if you know how cellulitis looks like, orbital cellulitis, it's the same. It's just that it's around the eye area. So there's periorbital redness, as you can see here, and edema. All right? So redness and swelling around the eye. There would be severe ocular pain and also visual disturbance. There may even be proptosis, ophthalmoplegia, or pain with eye movements. Ophthalmoplegia, basically, it's almost paralysis of the eye, and there would be eyelid edema and even ptosis. For investigation, the best initial investigation would be CT scan of the sinus, orbit, and the brain. This is to rule out intracranial abscess. Of course, you can do a full blood count. You will notice that the white blood cell would be elevated, and even the ESR. Clinical examination involves complete ophthalmological assessment, and you can also do a blood culture and microbiological swab to determine the organism. Therefore, you can proceed with definitive treatment with antibiotics. So treatment would be emergency referral, as this is a medical emergency, and commence IV antibiotics. Acute angle closure glaucoma, also known as narrow angle glaucoma. So what happens in acute angle closure glaucoma is that the root of the iris occludes the anterior chamber angle and prevents the passage of the aqueous humor from posterior to the anterior chamber. So the aqueous humor cannot reach outflow pathway. There is impaired aqueous outflow and it collects in the eyeball, resulting in rapid elevation of intraocular pressure. There would be raised IOP. It is an ophthalmic emergency and may cause permanent visual loss due to the increased IOP, which can damage the optic nerve. So as you can see in this picture, this is a comparison between closed angle glaucoma and open angle glaucoma. Okay, so basically what happens here is that the aqueous humor can't exit this part. Okay, it can't exit through the trabecular meshwork. It comes out here, it's supposed to exit here. But what happens when it comes out, it's not able to exit because it is blocked by the root of the iris. Okay, this part here, this iris blocks it. You can see in this picture, it completely blocks it. Now the aqueous humor, when it comes out, it builds up over here. Okay, it builds up in this part. So when it builds up over time, it compresses the lens, and that's why it's a medical emergency, because it can cause permanent visual damage. Clinical feature: the patient would come in with acute severely painful eye and also red eye, as you can see here. There may be headache associated due to the increased IOP, blurred vision, and also ocular pain. Okay, they will be seeing colored halos just like in cataract. The pupils would be semi-dilated, non-reacting, and might look ovoid, as you can see here. There is increased pupil dilatation, mydriasis, such as when watching TV in a dark room, and it worsens the symptoms because when a person watches TV in a dark room, or when they see something bright in a dark room, it will cause pupillary dilatation, which will decrease the outflow tract, because when the pupils dilate, it will block it even more. Okay, so if you were to do a physical examination, the eye would appear hard, and there is cloudy, dull, hazy cornea or corneal edema, as well as a shallow anterior chamber. So it's important to remember the clinical features, because these are what you can ask when you take the patient's history. Alright, so the next step, investigation, would be to measure the intraocular pressure, the IOP, which will usually be raised. So you use an ocular tonometry. So treatment can be medical or surgical, depending. So the first line treatment would be topical pilocarpine to induce pupillary constriction, and IV acetylozamide to reduce aqueous secretion. The long-term treatment, of course, would be surgical. So if they ask what is the definitive treatment, it would be peripheral iridotomy. But what is the first line treatment? That would be topical pilocarpine. This is open angle glaucoma. So remember, I said in closed angle glaucoma, the aqueous humor comes out over here and builds up because the iris blocks the trabecular meshwork. In open angle glaucoma, there is progressive decrease in visual acuity and peripheral visual field, usually in an elderly. What happens is the aqueous humor comes out, and it is usually due to obstruction in the trabecular meshwork, but it's not caused by the iris. Now, what happens is this can occur over time. Unlike in closed angle glaucoma, it's usually acute, very fast, and they will come to the hospital immediately with severe eye pain. But with open angle glaucoma, it can occur over time. It takes time to build up because the aqueous humor can still come out, but it may not come out as fast or fully as it's supposed to, because there is a blockage over here at the trabecular meshwork, but blockage is not full as compared to here where the iris completely blocks it. But here It's not by the iris and it's not fully blocked. So the aqueous humor is still able to go out, but it builds up over here. Whereas in close angle, the aqueous humor builds up and presses on the lens. So you can see over here, this is another presentation. In open angle glaucoma, there is a clogged drainage hole. Like I said, it's clogged, but it's not caused by the iris. But in closed angle, it's completely closed. It's completely blocked, and it's by the iris. So treatment, first line would be prostaglandin analogs, or you can give topical beta blockers and also acetylozamide. If you were to do laser or surgical procedure, you can proceed with laser or surgical trabeculoplasty, laser cycloablation, or artificial shunts. It's important to know the difference between open angle and acute angle closure glaucoma. In acute angle closure glaucoma, the drainage through the trabecular meshwork is completely blocked. It's completely blocked by the root of the iris. Whereas in open angle glaucoma, the drainage through the trabecular meshwork is not blocked by the root of the iris, but it may be clogged, and usually it's not fully clogged. Hence, drainage is inefficient and the pressure builds up over time. And of course, it can cause damage. Whereas in acute angle closure glaucoma, it's acute. It happens immediately. Patient comes in with severe pain on their eye, but open angle, it takes time to build up. So just look at this image. Go through this image again. As you can see here, the iris completely blocks it. Aqueous humor builds up, presses on the lens. But in open angle, it's not by the iris. It may be clogged or usually by something, and the aqueous humor can come out and it is unable to drain fully or efficiently, so it takes time to build up. Meibomian cyst is a retention cyst of the Meibomian gland. So Meibomian gland is a large sebaceous gland present in the eyelids, okay, which secretes lipids that forms the superficial layer of the tear film to protect evaporation of the aqueous phase. It presents as a firm painless lump in the eyelid, and most of the time it resolves spontaneously. But sometimes if it occurs again and again, or it does not go away, then that's when it requires surgical drainage. So the initial treatment would be to apply warm compress to the affected eye. 4 weeks after conservative management, if it's still present, then refer to an ophthalmologist. Alright, points of the nerves of the eye. So I would be talking about ocular motor nerve, or the third cranial nerve, the trochlear nerve, the fourth cranial nerve, and also the abducens nerve, the sixth cranial nerve. So just remember this LR6SO4O3. So the rest is supplied by cranial nerve 3. So LR6, the lateral rectus, is supplied by the abducens, the sixth cranial nerve. Superior oblique is supplied by the trochlear nerve, the fourth cranial nerve. OTA. Just remember this next three part like this. If you're weak in memorizing about the nerves of the eye, this will be really helpful. So OTA 3, 4, 6, just like LR6, SO4O3. Ocular motor is supplied by the third cranial nerve. T, trochlear, is the fourth cranial nerve. A, the abducens, is by the sixth cranial nerve. Now, same, opposite, same is the affected lesion, alright? So, if the lesion is, let's say, on the left side, it is usually the left brain that's affected. If it's opposite, meaning if the left eye is affected, it's the right brain that's affected. And here, same, if it's the left eye affected, it's the left brain affected. The lesion is on the same side, okay? So remember this OTA 3, 4, 6, same, opposite, same. So the first one, ocular motor nerve, or otherwise known as the third cranial nerve. So the third cranial nerve controls most of the eye muscles. It is involved in constricting the pupils, and it innervates the levator palpebrae superioris. Injury to this ocular motor nerve would cause dilated pupils or mydriasis and ptosis. Now, same side, I'm referring to the same side lesion, all right? So you can see here, this is the affected eye, this is the normal eye. The patient is actually looking straight. But when the patient is looking straight, look at the affected eye, it's going to the side. So there is mydriasis, dilated pupils, and there is also ptosis. Take note of the eyelid. Now, in trochlear nerve, the fourth cranial nerve, it is involved in controlling the inward and downward movement of the eye. The muscle involved would be the superior oblique muscle. Injury to that would cause diplopia. Diplopia is double vision on downward gaze. So basically, when the patient is looking down, like when they are reading or maybe they're walking down the stairs, okay, there is double vision. So there's vertical diplopia. And the lesion affected would be the opposite side. So remember, in ocular motor, it's the same side that's affected, meaning right eye affected, right brain. But in trochlear nerve, it's the opposite. So if right eye affected, it's the left brain. Similarly, left eye affected, right brain. Okay, so look at this picture. The patient is gazing to the right side. This is the normal one. Okay, but this is the affected eye. Notice how it's looking up, because the trochlear nerve controls the inward and downward movement of the eye. So over here, the normal eye, the patient is just looking normally, but the affected eye goes up because the eye is unable to look inward and downward. So that's why in a vertical gaze, meaning like if they were to read or look up and down, that is when they notice double vision. So remember that it is opposite side lesion, okay? Next is the abducens nerve. So the abducens nerve is the sixth cranial nerve. It is involved in allowing the eye to look outwards, okay? To look outwards. Lesion to that would cause diplopia. Diplopia again is double vision on lateral gaze, okay? Earlier it was vertical diplopia. In abducens, it's horizontal diplopia, okay? And the affected lesion would be the same side, meaning if the left eye is affected, it's the left lesion, the left brain that's affected. So here the patient is trying to look to the left, trying to look to the side, but this is the normal eye. When the patient is trying to look to the left side, this affected eye looks straight because they are unable to look to the side. So remember, abducens nerve controls the eye in looking outward. But when the patient tries to look the other side, the eye doesn't follow. The eye doesn't look outward. It doesn't move to that side. So there would be double vision on horizontal. So if you ask the patient to look from left to right, they will say there's double vision. But you can also see this eye doesn't follow outwards. All right? Just let's go through again through the pictures. So the first one, okay? When the patient looks straight, the other eye moves outwards, and there's also ptosis. That's in oculomotor. In trochlear nerve palsy, when the patient looks to the side, okay, this eye that's supposed to look inside and downwards doesn't, it goes up. In abducens nerve palsy, when the patient looks to the side, tries to look outside, the affected eye looks straight. So if you've reached this part of the video, thank you so much for watching. Do hit the subscribe button and press the notification bell so you don't miss out on any new videos. I post videos weekly, and see you in the next one.